Hello, everyone. I'd like to welcome you to this month's rounds. I'm Jennifer Jones, and I'll be the moderator for today's session. I'd like to thank those of you who are joining us remotely. We're here in the Elixir boardroom at Princess Margaret with a full boardroom. Today, we're going to hear from our speaker. As our usual format, we have our speaker, and then we have a little bit of time at the end for any discussions or questions that you might have. In order to give our speaker lots of time, I'll get started. Our speaker today is Bernstein. Laurie earned her PhD in psychology from Columbia University in New York and has been a licensed clinical neuropsychologist in Ontario since 2002. And she joined the University Health Network here in Toronto in 2006 and holds a position as a clinical investigator at Princess Margaret in the Department of Supportive Care and the Cancer Rehabilitation and Survivorship program, and is an assistant professor in the Department of Psychiatry at U of T. Her research interests focus on better understanding and characterizing the neurocognitive changes that cancer and or its treatment has on patients, both in the short and long term. And I think that's what we're going to be hearing about today. So her title today for her talk today is Neurocognitive Function in People Treated for Head and Neck Cancer. And Laurie, I will hand it over to you. Welcome.
Thank you. So,
yeah, is that unmuted, I think? Yeah. Okay. We have to be quiet in this room.
Thanks, Jennifer, and to the Consortium for inviting me. Welcome, everybody, I think there's some people from Ottawa and DC, it looks like. So, yeah, today I'm going to tell you about head and neck cancer and a study that I'm doing.
Just pull it closer to Laurie so everybody can hear. Laurie?
Okay. So, an outline of what I'm going to tell you about, a little history of cognition and cancer. If anyone's heard my talk, like I said, I'm just kind of interested in what leads up to where we are. Talk about how cancer-related cognitive dysfunction is studied, so CRCD for cancer-related cognitive dysfunction. Talk about what we kind of sum up, think of what we do know about it, what we know less of. Briefly talk about the impact it has on people, and then really go into, in more detail, the study that I'm going to tell you about today with head and neck cancer, why I decided to look at it, what might be different about CRCD in head and neck cancer compared to other patients it's been looked at primarily. This is one of the first times I'm actually presenting on something that has somewhat been finished. It is ongoing, so that's kind of new for me. Stay close. Yeah. So some of the results I'm going to be presenting has been submitted. Some was just published last month. Also want to talk to you about what's next and group discussion. So I'll sit down so I can stay. Okay. So the oldest description of cancer actually comes from the Edwin Smith Papyrus. I don't know if anybody's heard of this. This is 600 BC. 8 cancer patients were described. Breast cancer, one was male, which I thought was kind of interesting, and they talked about how trying to get rid of it, like they translated like a firebrand or something kind of not so nice. By the 1700s, early 1700s, surgery for cancer treatment was being done more regularly. 1898 was the first radiation being deliberately administered as a cancer treatment. In 1946, kind of the beginning of chemotherapy through a serendipitous discovery that nitrogen mustard agent has anti-cancer properties. Something a little related, or just something that I find kind of interesting in terms of why it was so late to be studying this, there was a study that came out in 1961 that basically surveyed a couple of hundred physicians and medical oncologists in the U.S. and asking them about disclosure of cancer patients. And at that time, more than 90% of the physicians said they did not disclose the cancer diagnosis. Okay, that's 1961. Only 15 years later or so, 1978, there was a repeat of that survey, and in fact, it had completely flipped. At this point, 97% of MDs said that they disclosed. Now, I don't want to get into what does disclosure look like, what's full disclosure versus partial, but they at least are telling people. So some of that is that in between that time, there was an increase in interest in psychosocial oncology in general, and that's been given as part of the reason. I suspect it also might have to do with this in the 1970s, informed consent for treatment protocols became mandatory. So, of course, how are they going to do research on this if they're not telling people about it? But a pretty dramatic change. So in terms of cancer and cognition more specifically, in 1980 was the first study that suggests that non-central nervous system cancers have cognitive impairment. This was an inpatient study. Didn't talk about treatment, just commenting that people in the hospital for cancer treatment had cognitive impairment. In 1995, so nearly 15 years later, was the earliest study where they're specifically talking about the relationship between chemotherapy and cognition, so the chemo brain or chemo fog, as being distinct from anxiety and depression. So until that time, when patients were reporting it or it was found, there was always this, oh, it's probably related to the psychological impact. In 2003, the International Cognition and Cancer Task Force was formed. They held their first meeting in Banff, Canada. One of the four founders of that is actually a Princess Margaret medical oncologist in Canada who retired a few years ago. In 2006, probably this group is familiar with the Institute of Medicine's landmark From Cancer Patient to Cancer Survivor document. In that document, cognitive difficulties, cognitive impairment is actually listed as one of the things that is needed to be studied, to be addressed by the oncology community. So until that time, and still, most of the cognition and non-central nervous system cancer studies have been done in breast cancer. Certainly, if you're talking about solid cancers, it's nearly all breast cancer. In 2011, the International Cancer and Cognition Task Force, the ICCTF, actually issued recommendations for how studies in cancer and cognition should be done. So this really did a lot toward moving things in a direction of some more consistency. So that was published in Lancet Oncology. And in that document, they recommended that studies, whenever possible, be longitudinal. They include before chemotherapy assessment, so pre-chemo. They include a control group, and they include measures of objective performance, not just patient reporting. And they actually gave a suggestion of a core battery that should be included of the objective. So how is cancer-related cognitive dysfunction assessed, or how is cognition, in fact, assessed in anybody, whether they're cancer patients or not? So two ways, subjective and objective. So by subjective, I'm referring to self-report measures. So, rate your memory on a scale of 1 to 10, or how are you feeling about your memory kind of questions, or patient-reported questionnaires. So rate your spouse's memory on a scale of 1 to 10, that kind of thing. Now, many questionnaires developed or have been developed for use in cancer on this, so FACT-COG is one of those. But there are others I use, including the MMQ. Promise has a couple of ones, and what's nice about them is that most of the time, and these in particular, is that you can give them to anyone. So although they may have been assessed with cancer, there's nothing in them that is cancer-specific. So you can actually give them to controls as well, and then you can get it different, right? So how is your memory can be asked to anybody, as opposed to the kind of questionnaires that are like, how's memory since you've been on chemotherapy? Click. Just sort of something to keep in mind if you're ever reading these studies, looking at. So the objective measures are referring to more cognitive tests. Sort of, instead of rate your memory on a scale of 1 to 10, but I might give you a list of words to learn, and you have to tell it back to me. Those have normative data, so by that we know how people kind of should do. So generally they're given to large groups of healthy people. We might compare a particular patient or a group of patients with people who are of the same age. And then you can actually get a percentile. How are they doing? Are they in the 50th percentile or in the first percentile and so forth? So cognitive screens that are used more often because they're easy include the mini mental status exam, the MOCA, the Montreal Cognitive Assessment Form. Has anyone heard of the MOCA lately? It's been in the news. Okay, so that is the test that Donald Trump took to prove that he was, he aced it, apparently. Okay? So that's kind of interesting. Of course, now that it's been plastered all over the news and everybody has seen it, this means now that it's kind of going to be difficult for anybody else to take it without being informed already. Like, oh, those are the 5 words I'm supposed to learn, and those are the 3 pictures I have to do. Then you have what are called the neuropsychological tests. So those are getting into more detail specific to particular cognitive domains. So I can test your memory, I can test your attention, I can test your visual perception. I can use them to diagnose something, so it's used for like attention deficit disorder diagnosis, or you have a dementia, and if so, what kind? Those kinds of things. What do we do with those objective measures? We can look at performance in the sense of accuracy. So some tests about how many you right. Sometimes we do an error analysis. So what types of errors do you make? When you tend to make the errors, we might look at response. How long does it take you to answer? We can also, and it's being done more and more in cancer, although it's still relatively new, is to do functional neuroimaging. So while people are performing these tasks, we basically image their brain, see what parts of the brain are more active than other parts of the brain. I'm not going to say anything other than about that than all. I'm not going to present any kind of neuroimaging. Subjective and objective measures have been used in both cross-sectional studies and longitudinal studies, but it's worth keeping in mind that how you analyze those are going to be different. So when you think about a longitudinal study, it's basically a repeated measure. You can imagine if you were repeating an objective test, then once you might actually get better, right? So kind of like the MOCA that Donald Trump took. The first time he took it, before, that kind of thing. So it's something to keep in mind. In addition, even within a objective measure, the test really does matter in terms of how sensitive is it, when do you give it, in terms of your interpretation. So I'm just going to show you an example of that because I think it's pretty telling in terms of the test that you give, how much it can matter. So I'm going to use this. Can people see where my mouse is? People can see it where they are? Okay, so this is basically 3 cycles of chemotherapy, before, after, before, after, before, after. So 1-1 is before their first chemotherapy, 3-2 would be right after their 3rd cycle of chemotherapy. Okay? So given the test 6 times, up here where these red arrows are is the mini mental status exam, which is kind of like the MOCA. Very related. And what you can see is if this is all you gave, your interpretation of this would be what? Chemotherapy has no impact on cognitive function because there's absolutely no change. Okay? In contrast, this bottom where the squares are, that's what's called the HVLT. It's a verbal learning test. Okay, so what you can see from that is, in fact, chemotherapy does have a negative impact on verbal learning. So here's the first time they see it, and there's a drop. And there seems to be some recovery, and then there's a drop, and so forth. Okay? So you can imagine, so first of all, you say chemotherapy, in this case, actually does impact. Now imagine if you had only tested immediately before each cycle. What would your interpretation be? You have it here, you have it here, and you have it here. You might actually interpret that chemotherapy is good for your verbal memory, right? Because this isn't taking this process. I'm going into all this detail I kind of think it's interesting, but it also impacts how we then analyze our data. So what is the gold standard of objective cognitive assessment, including different cognitive domains? So you need to look at intellectual capacity, attention or concentration, language, processing speed, memory. There's different kinds of memory. Memory for verbal information versus visual, how well you can learn it, how well you retain it, and so forth. Executive functioning includes things like planning, organizing, inhibiting, multitasking, and so when we think of, in general, I said that most of the studies have been done in breast cancer. What has been found so far, in general? Okay? So self-reported cognitive function is very high. Up to 75% of people during and after treatment will report some measure or some amount of difficulties in concentration, attention, memory, and so forth. When you're talking about objective function, chemo-treated patients, again, most of the studies about chemotherapy or not, have more severe CRCD than non-chemo. So compared to women who say have surgery alone. But non-chemo patients can also have CRCD too. So they can look worse than healthy control. That's something to keep in mind, and this is all part of the what does chemo do that's different from just having cancer. The other thing that's worth pointing out is that CRCD in this population, breast cancer, can persist for years. There was a study that looked at people 20 years after they had chemotherapy, and they were worse than those, or at least a subset. It's about 20% of people seem to persist. Okay, so what about the impact? So what, they do worse on these tests, okay? What is this in sort of the rest of their lives? Evidence, it's reducing health-related quality of life, more anxiety, more depression, less satisfying relationships, reduced daily functioning, reduced employment, and it's a pretty substantial cause for disability. There was a study that looked at people 12 to 18 months after they've been on disability, and in 18 months, like 20%, 22% are listing cognitive impairment as the reason that they can't. So, where's head and neck cancer come in on this? So it's a new population. It's fairly different than breast. Honestly, the interest came from the clinical team who approached me because they were seeing a patient who was cured. They were seeing them in long-term follow-up, and they had pretty severe cognitive impairment. And they came to me saying, what's wrong with this person? And I think they have dementia, and I want you to see them. That's really where it came from. And then when I started looking into it, there was virtually no data out there on this population. Breast cancer patients have kind of chemo cocktails. They have a lot of different chemotherapy agents. These head and neck cancer patients tend not to. However, they have radiation treatment, which is kind of close to the brain. Not directed at the brain, but it's close to the brain. I'll explain why that's relevant in a minute. In addition, we thought that they may be more vulnerable, right? So head and neck cancer patients have a higher incidence of smoking and drinking than breast cancer, for sure. It's actually a risk factor to developing head and neck cancer. And so that kind of alcohol substance use might, in fact, put the brain in a more vulnerable place, perhaps, to be more susceptible to the treatment. That was the reason that we thought possibly things might be going on. So I mentioned radiation near the brain. I just want to briefly say where is that coming from? So we know from radiation that is directed at the brain on purpose that there are both acute and long-term or delayed effects. So in the acute stage, you have nausea, you have vomiting, you have those kinds of things. It resolves and improves. Okay? But after, what you see is a delayed onset neurocognitive decline. So these are people who, for instance, small cell lung cancer may have prophylactic brain irradiation to avoid that cancer metastasizing in the brain. They don't have cancer in the brain, but they're given the radiation to prevent it from spreading. And what was found is in those people, they're fine right away after the radiation, but a year to 10 years later, they start to have it. You look at what's going on in the brain, lots of changes, cortical atrophy, white matter problems, endocrine dysfunction, secondary tumors, and neurocognitive decline. Okay, so a very different kind of profile from what you see in terms of the chemo. So this is kind of another sort of summary. What we see in terms of what does chemo do for patients who are tested before and after chemotherapy, we see pre-treatment problems. Okay, so about 20% of patients actually have deaths before chemo. That's In terms of temporal profile, while people are on chemotherapy, they're at their worst. There is some improvement, but not necessarily to baseline, and then improvement happens up to 2 years. Yep. I don't know what happens after that. There is a dose dependence. The more chemotherapy you have, the more likely you are to have CRCD. And as I mentioned, self-reported measures, or may have mentioned, are higher. So when people are saying, how is your memory, you're getting a lot more people who are saying there's problems than you'll see on objective tests. What seems less certain, which cognitive domains are affected, which might be more preserved, what are the patient-related risk factors, does it matter how old they are, what about the particular chemo regimen, other things in their background that may make a difference, what about endocrine therapy, so chemo might push people into menopause, the women anyway. Some with breast cancer, they may be on an anti-estrogen agent. That can have its own impact. But anyway, that improvement and then stability is very different from the radiation to the brain picture, which is you're fine right away. Okay, so head and neck cancer are kind of in this interesting in-between stage. They don't get radiation direct to the brain, but it's nearby, and there can be scatter at lower doses. So one of the questions is that enough that it might still have some neurocognitive? So locally advanced head and neck cancer incidence is rising related to the human papillomavirus, or the HPV virus. It's also kind of been in the news. You may have heard about it. They don't have surgical treatment, so it's another difference between the other cancers. Pre-treatment in the other cancers is before surgery, right? So you've got the anesthetic effect. These people are diagnosed by needle biopsy, and they all receive radiation, and then some also receive chemotherapy, usually a single agent. So we decided to do a pilot study. This was back in 2011 after the medical oncologist approached me. We decided to look at 10 people, just cross-sectional, anytime after treatment. They were apparently stable medically. They had to be at least 6 months, no evidence of recurrence. They hadn't had surgery. There really wasn't much in the literature, nothing in terms of comprehensive neuropsych. So I put it, we decided to go big, or rather I'm the one that decided to go big. They were very skeptical, right? Because what is big, right? Well, I told you what the gold standard was, right? So it's quite a bit. So this is what my going big was, looking at all cognitive domains, not language. I actually took that out because of the so many people whose English is not their first language, and language tests and neuropsych are very sensitive to that. But separated verbal versus visual memory, and self-report, we went with the FACT-COG. In addition, I looked at some quality of life, fatigue, and stress measures, mainly because how people are feeling that way can actually impact cognitive performance. So people who are extremely anxious or extremely depressed tend to do badly on certain types of cognition. So we wanted to be able to do that. So we did it. We had this initial study, this feasibility, single arm, and what do you think happened? Everybody was able to do it without really incidents. They were interested. It was easy to recruit. And what did their data look like? So this is just 10 people, just focus on, just basically each panel is a different cognitive domain. Each bar is a single patient. Anything that's going down represents a deficit. The point of this is really to show that, one, there's a lot of consistency with deficits, much more than what has been found in breast and colorectal. Okay, it was like 9 out of 10 patients, and that amount of deficits is much larger. Of course, small sample size, no baseline, no control. They were on average 20 months after radiation. So what's next? The longitudinal study, and that's the main thing of what I'm going to talk to you for the next 20 minutes or so about. So we decided to investigate this. The battery is about 2 hours, depending on how chatty people are, and assess the objective. And we basically did the same battery that I had just pitched earlier, testing all the different domains, and patient data as compared to control. Okay. One thing I want to point out is that each test or each domain had at least 2 separate tests that have normative data. So what you can do is you can find like a T-score or a Z-score, like a percentile of the different tests, and then you can combine them to give a more reliable kind of measure of that domain. And we were looking for 80 patients and 40 controls. Right? Nothing really, we excluded nasopharyngeal cancer. It's a different type. Cancer is much higher, closer to the brain. We cut them out for different reasons, make different treatments, and the kind of usual exclusion criteria people are interested in. So here's the design: pre-treatment, 6, 12, 24, and 60 months. I'm not presenting that. I'm only presenting up to the 21. Again, that comprehensive battery, including also patient-reported outcome measures, and we also took the blood. Okay, I'll tell you why here. In addition to the demographics and comorbidities, we were kind of interested in mechanisms, if there's anything going on pre-treatment in their blood that might be associated with cognitive performance. So cytokines, inflammatory molecules, there was some evidence at that time that that can be associated with certain types of cognitive abilities. We also needed to make sure thyroid was normal, liver function, those kinds of things. We also took either blood or saliva samples for a one-time genetic. What we're looking for is genetic mutations that we know are associated with dementia later in life. So ApoE is the most common one. So we did that as well. And again, 2 hours. So here's just kind of the demographics of the patients and the participants, I should say. So the range was the same. They ranged between 41 and 75 or so. Patients were slightly over 58 versus around 55 age. What you see, a big difference is patients were much less educated. So that was a significant difference. Even though we really wanted people at the same age, there were more of our head and neck cancer patients without a high school diploma. They also were significantly higher smokers, which was not surprising. Significantly higher drinking, which was also not surprising given that's a risk factor. And I'm not sure people are in this group are interested, but basically most are oral pairings. This is typical of the incidence of these types of things. So what's going on at baseline? That's our first question, because we know in other cancers it's been reported that people have pre-cancer impairment. Okay, I know it's a little small. On the x-axis are the different cognitive domains. On the y-axis is just the mean Z score. It's just your average score. Okay? At 0 would be you're at the 50th percentile. So a couple things I want to point out. One, as a group, people are all within the normal range, ranging from 15th percentile to 70th. Okay? There were no differences between patients and controls in any cognitive domain except for intellectual function, where surprisingly the patients were better, despite being a little older, less educated, more drinking, more smoking. So we could talk about that later if you want. I'm going to pass it over, but it might have to do with selection bias, who's interested in doing this kind of study. It could be motivation to do well. There's different kinds of things. But in no other domain was it so significantly different. But you might kind of notice the verbal and visual memories are kind of low, right? What's going on there? That 15th percentile, that's kind of different. So what we looked at is the frequency, how many of the patients and how many of the controls actually fell in a clinically impaired range, which is less than 2nd percentile, okay? We have nearly 20% of patients and controls performing in an impaired range on our test. So what does that say? One, this is saying that, do I think that patients and controls are both happen to be impaired? No, I think there's something with the tests and the norms and or the experience of giving these tests within this battery. Keep in mind the normative data are kind of from a standalone. So if we didn't include the control, which a lot of the previous studies, earlier studies have done, they have no control, our conclusion would have been patients are at risk of having memory impairment before treatment. But because we have the control, We don't make that conclusion. What about self-reported? On the other hand, okay, another slide. But what I want you to focus on is this top row in particular, and that's the FACT-COG total score, but we also looked at subscales. And yes, we see a significant difference there. So patients are reporting more cognitive symptoms, reporting worse cognitive functioning. They're also reporting more anxiety, they're also reporting more fatigue, and they're also reporting poor quality, well, not the quality of life, because we couldn't give that to our control, but depression. Okay? So, how are we? Okay, so I've got some time. This is kind of trying to figure out what factors, my interest is like, what are the risk factors to predicting cognitive function? So we could tell a person when they're coming in, you may or may be more risk than others. So we're looking at the factors in a multivariable analysis of what is associated with either the self-report or the cognitive function. There's a couple of things I think people might be interested in. So one I don't put up there, education is across the board associated with cognitive performance, not surprising. People with a higher level of education do better on the test. Okay, but what else? A couple of things I thought were somewhat interesting. Okay, this is your self-report perceived cognitive impairment. Older people report less cognitive impairment. Okay, that's one thing. Somewhat interesting. Women have better memory, but worse executive function on this test, okay, that we gave. Smokers, okay, I'm showing you what's significant, and then I'm telling you the direction. Smokers had poor performance on IQ, memory, verbal memory, speed, and executive function. Okay. Concussion. I want to talk a little bit about concussion. So something that we did that usually is not done because I have an interest in head injury is we really got into, so we excluded anyone who had an obvious documentable, traumatic brain injury. But what I did was I looked more into that concussion history. So, yeah, I was playing hockey when I was 10 and I was knocked out for a few seconds, or may not have lost consciousness, but I felt dizzy and I had to stay home from school for a weekend. We counted that as having a concussion. Okay, we looked at that. And that ended up being a significant contributor. So both to your perceived cognitive impairment, quality of life, fatigue, and visual memory. Interesting, it's not expected, right? So people who had concussions didn't do that. Okay. About this, people were interested. So this is kind of small, but this is now into the longitudinal kind of flow of what retention and what recruitment looks like. So we approached 143 patients. Here's our 80 patients, 40 controls. At 6 months, 12, 24. I'm just going to skip down to here to talk about how well we were able to retain our participants. So 35 out of 40 are still on 2 years later, and in fact, did all 4 of them. Didn't miss any. Patients of the ones, so 9 out of the 80 actually needed to withdraw. Either they died or they progressed, which was the immediate exclusion criteria. So of the 71 who have not, their disease is under control, 63 of them are still on study. Okay, that's 89%. And 75% of those did all 4 of them. So what about the analysis? There's a lot of work in how to approach and how to analyze these kinds of data. Papers written on this, and there's different approaches. So I'm going to tell you about 3 approaches that are done, or some do one and some do another, and basically we did all 3. Like, I really want to know what's going on. So the first is a pretty basic, let's just look at the mean level of performance. The problem with that is it doesn't take practice effects into account. It doesn't take any of the other things that we know can have a difference into account. So this is the mean age-corrected set score. And we just basically look for a time by group interaction. Okay? And then we can look at patient versus control at different time points. The second method is more recommended in this field, and that's looking at standardized regression-based models. So basically what that does is It's a way of using the controls to get a measure of the practice effect, as well as being able to adjust for variables that we know will impact later performance. So their baseline level of performance, for instance, with their level of depression or anxiety. And the third way that we looked at that I'm going to show you is actually looking at the frequency of people who had a significant drop compared to their baseline. We took a fairly stringent, they had to really decline, so a drop of 1.75 is a big drop. So this first figure is basically the average of all the cognitive domains together, and it's just the mean, that first way I mentioned in terms of the mean score. So what you see on the x-axis are the assessments, baseline 6, 12, and 24 months. The mean Z-score, in this case, people are falling between the 35th, as a group, between 35th and 50th percentile. So nobody's impaired. As a group, they're not impaired. This is not a demented population, right? But what you see is blue is patients and red is control. What I think is you can kind of see pretty obviously, that's significant interaction. What you're seeing is that patients are staying the same and the controls are getting better. So this kind of practice. Okay. So next we're going to look at the standardized regression-based model, looking at that. This next slide is breaking it down by domain because I want you to get a sense, is it in, like, are all the domains affected or what's happening? So now what you're only going to see are the patient lines. Up here at 0 where they start, that's kind of, if they stayed up there, that would be no change. Or that's where they would be expected to be. What you can see, I hope, is intellectual capacity, concentration, basically all of them, except for maybe visual memory, are declining over time. And these particular, we did it in different ways, but this particular one that I'm showing you is adjusting for just for the practice effects as well as the baseline age, education, depression, and so forth, which is also important because we knew our patients were less educated, so we need to take those things into account. This is basically kind of some of the same data, but this is what was presented in the paper that's been published, because this is showing the error bars, so the 95% confidence interval. So you see that anything lower than 0 there is a deficit. Okay. You can see intellectual capacity, concentration, except for at 6 months, verbal memory, and then global cognitive score definitely declining over time. What about the frequencies of decliners? So we can look at frequency of decliners among all the participants, which I'm going to show you here, but we could also look at it depending on only those that completed all 4, but for ease, I'm just going to show you this one in terms of all participants. I know this is a crazy, busy slide. Let me just explain. This was a reviewer who thinks p-values are the devil and everything should be effect sizes and confidence intervals. So what you see is that 6 months, basically nothing's bolded. There's nothing significant. Things are going in the direction in terms of odds ratios. Everything is over 1, except for executive function and visual memory, but nothing significant. So there is no, patients are not at an increased risk of having cognitive decline compared to controls at 6 months. Well, what's happening at a year? So at a year, what you see is intellectual capacity starts to be significant and verbal memory. What's happening at 24 months? Intellectual capacity even more so, verbal memory, and now executive function. What you're seeing is a continued decline. Okay, so this next figure is something that was published, and this is basically graphically showing in terms of that global cognitive functioning, the percentage of patients who have a significant decline at each of those assessments. So you see at 6 months and 12 months, patients, about 15% of them have a decline. Doesn't really change much, whereas controls, there's some improvement, but look what's happening at 24 months, right? You have about 35% of patients who have a decline in other single control. What's happening with self-reported symptoms? Again, there's a lot of numbers, but the main conclusion, take-home message of this is Patients across the board are reporting worse cognitive functioning than controls, and there was no change at any time. Totally stable. What about the factors associated with CRCD? So what about all that other stuff I did, all that blood work, all those, well, nothing at this point turned out significant, so no associations between any consistent laboratory parameters and cognitive function. The genetic markers weren't unpredictive. We didn't see any consistent differences between the patients that had radiation alone versus those that didn't, although we only had 14% that only had radiation, so that might be a power issue. We also looked at radiation total dose to the brain. Just looking at that level, not significantly correlated with cognitive impairment. So, to start to summarize, what do we know from the objective CRCD? So, head and neck cancer patients did not have pretreatment objective deficits greater than control. They have cognitive deficits 1 year post-treatment. It involves multiple cognitive domains, and at least the risk seemed to worsen by 2 years. That risk of that delayed impairment was very high, with 35% of patients having quite a significant decline. And certainly that cognitive trajectory looks very different from how it's looked with breast cancer. Self-report, head and neck cancer patients are reporting worse cognitive functioning both before and after, along with reporting worse, psychological factors, and those are basically stable once you're at 12. So in terms of take-home messages, so people treated with head and neck cancer are at significant risk of the sequelae. Impairments are observed in several cognitive domains, intellectual functioning, verbal memory, executive function. In terms of what's happening upcoming, certainly what we're trying to do is a more detailed brain dosimetry analysis. So trying to look at what parts of the brain, what lobes of the brain are receiving what doses, and seeing if, like, the left temporal lobe is receiving more radiation, are they more likely to have a decline in verbal memory? And as far as the question of will it improve, like maybe they're now at the bottom and they're going to start to improve, maybe they'll stabilize, will they worsen? We really don't know, so stay tuned, because we do have a 5-year follow-up plan. A couple people are already at that 5 years, but it's going to be a couple years before we finish. Lots of people to acknowledge, in addition to our funders and the patients participated. Lillian Sue, Alvy Razak, Alona Zerda Medoc were really involved. Katlea Chirona, psychometrist in the RA, who is really responsible for all of that great retention. Greg Pons, biostatistician I work with, he's at McMaster University, plus other medical oncology, radiation oncology, and David Goldstein, the surgeon, biopsy to confirm diagnosis. So that's the end of the formal presentation. I'm at 40